Hi, everyone. I'm Dr. Axel Siu, the president of the Asian Society for Emergency Medicines. It is really our honor to have everybody to be here, friends from Hong Kong, and also from the other parts of Asia to attend this academic meetings of Asian Society for Emergency Medicines. This is the third time that we organize these academic meetings in this year, and every time we have invited representatives from the many from our Asian colleagues to give some talk and also teachings on various aspects on emergency medicine. This time, we are also glad that to have representatives from India and also from Philippines to give us two presentations. And also we have guest speakers from UK, Dr. Ted Hassan, the past president of the Royal College of Emergency Medicine, but this time he will represent the South Asian Collaborative for Emergency Medicine to talk something about how we can collaborate to facilitate the development of emergency medicines in in especially the South Asia. So without further delay, I would like to introduce our first team. I should say it's a team. To give us talk about the team is led by the Professor Raja Duray, and the team will talk about the topic of the presentation will be this focus, a new area of focus in acute care, a case series. He will give us some insights on the applications of a focus in emergency medicine, and also during this presentation we will have some questions. So we invite all the audience, they can use the poll functions in the Zoom to give us your view and also the answer for the different questions. So let's welcome Professor Raja Duray.
Thank you, Dr. Axel, for that nice little introduction. Good day to one and all present here. I am privileged and equally honored to be part of this wonderful EM academic experience. Can I do my slide sharing, Axel, if you don't mind?
Okay. You should have the right to share your okay. Yes. Okay, we can see your screen.
Yeah, thank you very much. So my name is Dr. Raj Duray. I'm a senior consultant and head of the Department for Emergency Medicine and Critical Care from Apollo KH Hospital, Melusharam. I'm a national vice president for Society for Emergency Medicine, India. I'm going to talk about POCUS and the case series we documented in our department. During the unprecedented pandemic, where acute care faced several challenges, one among them is examination of critically ill patient in ER and ICU. Whether during COVID or not, we emergency physician wanted minimum exposure, quicker diagnosis, less complication. Ultrasound was definitely a game changer during all these uncertain times. Though POCUS in emergency medicine is not a new entity, never a new entity, but it has been widely applied during COVID times, and most of the patient scenarios in today's case series were from those times. So I would like to take this time to devote my special thanks and gratitude to our hospital, Apollo KH Hospital, the Society for Emergency Medicine, ACM, HKEM, HKEMS, EM, and Dr. Axel for the kind opportunity given to me and to my team. During this academic meet, though the academic meet is in Zoom platform, we thought we would bring in more interactions by poll questions and thereby using interactive pictures and videos. We have framed a few poll questions in our presentation, where a specific objective question will be focused to the audience to get the most appropriate answers. The time given to the audience to submit the poll question will be 30 seconds. And I am sure that host IT team and Dr. Axel will pitch in for technical stability. Presentation will continue soon after the time period is given for the poll. So people, let's roll this presentation. So the objectives of my presentation includes talking about the point of care ultrasound, its applications in ED, the case series from our department, the recent advances, and few take-home points. So what is POCUS? POCUS is a point of care ultrasound examination that is performed at the bedside and is interpreted directly by the emergency physician. POCUS offers us the opportunity to avoid delays in acute care due to wait times for confirmatory imaging studies. Traditional conservative models involves delay in performance delay in interpretation, as well as delay in obtaining results to the treating team. Focus avoids this method, and it is one of the most important point of care investigation in hemodynamically unstable patients. It also helps us to arrive to a quicker diagnosis, thereby reducing the length of stay and the patient satisfaction. So is ultrasound a new stethoscope? I think the answer should be clearly no. Though focus is a powerful adjunct to clinical assessment, but never a replacement for proper history collection and thorough clinical examination. Application of focus in the emergency department. Focus can be single targeted or multiple targeted, narrowing down to a cause in the case of cardiac arrest or in a polytrauma patients, identifying the probable cause of breathing difficulty in a tachypneic patient or in a patient with chest pain. Single targeted focus include ocular ultrasound, ultrasound for invasive procedures, the lung or the cardiac ultrasound, abdominal soft tissue ultrasound. So these are all the types of probes we use. I'm sure every emergency patient would have been aware of all these things. So curvilinear probe, linear, and the cardiac probe used for cardiac ultrasounds. So as previously mentioned, all the scenarios are from the ledgers of emergency and critical care department of Apollo KH Hospital. And I would like to disclaim the following before we proceed in our case series. All the cases discussed under this topic were stabilized appropriately under ACLS and ATLS protocols, and before taking up these patients for point of care investigation. And complete clinical and complete course of treatment are not discussed in the presentation, as it is beyond the purview of this presentation. I would like to introduce two of my consultants who will be sharing the stage with me and will be my co-speakers for this session. Dr. Dinesh, Dr. Naira will alternately take you through our case series with interactive poll questions. Write down. Here comes the first poll question. Over to you, Dr. Axel. So the poll question will be, identify the region of focus and what is being measured here. Your time starts now. To those who have joined late, this presentation will have interactive poll questions in between, and you guys will be given 30 seconds to complete the submission of your response. The first poll question is on the run.
Okay, time's up.
Good evening. I'm Dr. Naira, a consultant emergency medicine and ICU from Apollo KH Hospitals. Here we're starting with scenario 1. This is a 55-year male who was brought to ER with alleged history of RTA with loss of consciousness for 15 minutes and 2 episodes of vomiting. Patient was initially assessed as per ATLS protocol and stabilized accordingly. On examination, his GCS was 8/15, bilateral pupils were 3 millimeters, sluggishly reacting to light. Pulse was 60 per minute, BP was 80/50 millimeters of mercury, saturation was 84% in room air. A laceration of 5 into 2 centimeters were present over the left temporal aspect. Patient was planned for CT brain after stabilization. Meanwhile, an EFAS scan including lung ultrasonography was done, which was negative. A point of care ultrasonography for optic nerve sheath diameter measurement was done. So this is the image showing anterior transbulbar ultrasonography. Here, a high frequency, high resolution linear array probe is used. The probe is gently placed on the closed eyelid with gel and adjusted to a suitable angle to display the optic nerve. So we can see, as in the poll question, this is the optic eye. This is a region is eye, and what is being measured is the optic nerve sheath diameter. So optic nerve sheath diameter is determined by measuring the diameter from the inner edge to inner edge of the optic nerve sheath 3 millimeters behind the optic disc, which is used as a reference point. So in our patient, we did an ultrasound measurement of the same, which showed a diameter of 7.67 millimeters on the right side and 7.23 millimeters on the left side. So in suspicious of raised ICT, we initiated early anti-edema measures as per the institutional protocol. A follow-up CT brain of the patient revealed a 9 millimeters thick acute subdural hematoma and left frontal and lateral temporal convexity. A midline shift was also present. Thus, the focus in this case has helped us to identify early rise in ICT and also initiate early anti-edema measures. Here's the reference article for the same. A thesis on integration of ocular focus as a part of EFAST was done and submitted from the Department of Emergency Medicine, Apollo KH Hospital to SEMI. Several studies have confirmed the reliability of the ONSD measurement in the evaluation of raised ICP by ONSD measurement with a sensitivity of 95% and a specificity of 92%. Here's a meta-analysis which was published in the Journal of Critical Care. It's optic nerve sheath diameter measurement for predicting raised ICP in adult patients with severe traumatic brain injury. So the reference articles for the same.
Now the time for the next poll question, which is the normal ONSD in adults. Option A 3 millimeter, option B 4 millimeter, option C 5 millimeter, and option D 2 millimeter. Your time starts now.
Okay, time's up. Here is the distributions of the answers by our audience. So about 47% of our audience chose a 5 mm, and second by the 3 mm. Only a few chose a 4 mm or 2 mm. So I will pass back to the speakers.
Good evening. I am Dr. Dinesh Kannan, Consultant Emergency Medicine, Apollo KH Hospital. We will move on to the second scenario, blunt trauma. We received a 24-year male who was referred from another hospital with an alleged history of RTA and blunt trauma. There was no injury elsewhere. The patient was initially assessed and stabilized as per ATLS guidelines and stabilized accordingly. On arrival, his TCS was 6/15, pulse rate was 118 per minute, BP was 80/60, and saturation was 90% in room air, and respiratory rate was 28 per minute. His pulse volume was very low, and extremities were cold. His capillary refilling time was prolonged, and we did an abdomen examination, which was rigidity was plus and distant. Next slide. After initial resuscitation, we proceeded with EFAS examination, a major area of focus used routinely. The EFAS assessment done revealed a free fluid collection in both hepatorenal and splenorenal state. This EFAS examination was extended to rush examination to rule out other cause of shocks. Next slide. Components of EFAS. The components of EFAS are justified view to view the pericardium, right upper quadrant view to view the Morrison's pouch and right costosphenic angle, left upper quadrant view to view the splenorenal recess and left costosphenic angle, the pelvic view to view the bladder in male and pouch of Douglas in female. The lung window with extended EFAS, we can diagnose the pneumothorax. Next. So this is the EFAS scan image from our patient. which was showing free fluid as a black anechoic region. In the right hand side, we have the image from the left upper quadrant showing collection of fluid between spleen and kidney. The left hand image is from the right upper quadrant. We can note the free fluid collected between liver and kidney. Next. In this image, the right hand side, we can clearly appreciate diaphragm, liver, renal capsule, and the kidney, which is normally seen in healthy subjects. Whereas the left hand side, we can see the liver and kidney containing free fluid. Next slide. The right hand side of the image shows normal splenorenal space. In the left hand side, the space is filled by free fluid between spleen and kidney. Next slide. Additional application of focus. Focus can be extended to visualize IVC in subsequent long axis M mode to measure the fluid responsiveness. In the same patient, IVC was visualized by transabdominal long axis view, and the patient's IVC collapsibility was more than 50% with respiration. Here, the left-hand side image shows a collapsible IVC of less than 1.5 centimeter, which indicates the patient may be responsive to fluid. Whereas the right-hand side image shows non-collapsible IVC, so the shock in this patient may not be responding to it. Fluid resuscitation based on IVC collapsibility. The measurement of IVC diameter and respiratory variation with collapsibility index has a pooled sensitivity of and specificity of 63% and 73% respectively. Based on the studies as cited below, IVC diameter less than 1.5 centimeter indicates volume depleted state, whereas IVC diameter more than 2.5 centimeter indicates volume overload state and non-responsiveness to fluid. But IVC diameter between 1.5 to 2.5 centimeter is less predictive of responsiveness. Hence, sole interpretation of IVC is poorly correlating, hence should be used in conjunction with other clinical parameters objectively for resuscitation. Next. This is the EFAS algorithm. So, after initial assessment and primary survey, the patient may be categorized as unstable patients and stable patients. The patients who are unstable with EFAS positive demand an immediate operative exploration without delay. Patients who are stable, unstable, and with EFAS negative should be further evaluated with CT scan. Patients who are stable and has a positive FAST scan should be evaluated furtherly with CT. The patient who are stable and EFAS negative should be observed with serial EFAS and CT scan as demanded by clinical scenario. Next slide. Thus, in our case, focus helps in us in detection of cause of the shock, that is intra-abdominal bleeding, and we were able to timely resuscitate by fluid and early resuscitation. Next.
Okay, it's time for the third poll question. So it is going to be a video question. So where we are going to place a video and expect you all to answer the question. So we'll play the video. This is a scenario. A patient sustained blunt trauma to the chest following breathing difficulty, following which he develops breathing difficulty, and ultrasound was performed on him. What does this image show? Option A is lung sliding sign, option B free fluid, and option C consolidation of lungs. The video will be played in the next slide. So option A, lung sliding, option B, free fluid, and option C, consolidation. What is your best choice? Over to Axel for the poll response.
You can mark down your choice in the text box.
Shall we go to the next poll question and
Okay.
see the response for the same?
Okay, this is well,
Okay, the next poll question. This is the M mode of the lung ultrasound, which shows the following image. Option A, seashore shine, which indicates pneumothorax. Option B, seashore shine, which indicates normal lung and no pneumothorax. Option C, the stratosphere sign, which indicates pneumothorax. And option D, the stratosphere sign, which indicates normal lung and no pneumothorax. Your time starts now.
So coming back to the scenario, it's a goal-directed echocardiogram.
before that, this is the poll result. And more than 50% of the audience saw answer C. Okay, I would like to pass back to the speakers.
So coming back to the scenario, goal-directed echocardiography. So this is a scenario, blood outside the heart. We had a patient, 66-year male, who presented to AR in a drowsy state with history of chest pain 2 hours ago. The patient was initially assessed and stabilized accordingly. On arrival, his BP was 60 by 40 millimeters mercury, pulse was 35 per minute, saturation was 82% in room air, and respiratory rate was 26 per minute. His GCS was 7 by 15. Apart from that, he had distended neck veins and there was reduced intensity of heart sounds. He had a history of systemic hypertension for 10 years. A 12-lead ECG was done, which showed ACS, ST elevation MI, anterior wall MI. A point of care ultrasonography showed fluid in pericardium, cardiac tamponade, anterior wall left ventricular apex hypokinesia with interventricular septum akinesia. So here on the left side of the screen, we see that there is a collection of fluid within the pericardial sac in the 4-chamber view. We can see that normally a little amount of fluid is present, but here there is large amount of fluid. On the right side of the image, you see in the subcostal view, there is a large amount of fluid collection within the pericardial space. So the patient needs urgent pericardiocentesis, which is a life-saving measure for him. So here you can see it's a parasternal long axis view, wherein you can see the fluid collection within the pericardial space around the heart. So these are the additional views of the heart. Here you can see that there is a hand probe position for the parasternal long axis view. You can see that there is a low frequency probe is used with the optical marker facing the right shoulder. So you can see the image right down. You can see the images, chambers LA, LV and RV. So we have seen in the previous image, the collection of fluid in the cardiac tamponade can be easily assessed. The second image is a hand and probe position for parasternal short axis view. The same parasternal long axis view, if you turn the probe with the optical marker facing the left side of the patient's shoulder, then you can get a short axis view. The best position to view the cardiac contractility. So you need to place the probe in such a way that the papillary muscles are visualized. You can get to know the cardiac contractility. The third image shows the hand and probe position for apical 4-chamber view. Here you can see the probe is being placed in the apex with the optical marker facing the patient's left shoulder. And in this image, you can better appreciate the dimensions of the 4 chambers. Usually in case of embolism, you can see the RA and RV grossly dilated when compared to LA and LV. These are all the normal images. Next. You can see then another view. This is a subcephalad or subcostal view, which is helpful. We can, as we have seen in the cardiac tamponade case, this will be helpful in such cases. And also, apart from that, we can use this in cardiac arrest. So because it does not interfere with the chest compressions. And on the right side of the screen, you can see that apart from all the cardiac views, you can also visualize the IVC. In the M mode, you can see the dimensions of IVC. It is collapsibility or distended IVC in cases of pulmonary edema or fluid overload.
It's time for the next poll question. Again, this poll question is going to be of a video type. So I'm going to play a video and tell you the scenario. So the audience have to identify what exactly the complication is. So this is a patient who was brought to emergency department, a 60-year-old male with signs and symptoms of acute coronary syndrome, and STEMI was diagnosed in him. Before he was taken up for revascularization, an emergency physician done a cardiac ultrasound, and we happen to find this in the image. So what would be the probable diagnosis? So what is a probable complication for our patient who presented to us with STEMI? He was directly handed over to the cardiothoracic surgeons where he was taken up for surgery. That is a clue involving the same. So what is a probable complication, Dr. Axel?
And 6 persons give the answers, and
The probable complication is MR. Moving on to the next scenario.
yeah. Please go on.
An invasive procedure in a patient with severe thrombocytopenia. A 28-year male with dengue fever was referred from elsewhere with severe thrombocytopenia. He had a deranged renal parameters and anuria. Blood investigation was done outside, showed a total count of 5,400 cells and platelet count of 12,000. He had a hemoglobin of 10 gram per deciliter. He presented with issue of bleeding gums. On arrival, his BP was 100/70. Pulse was 108 per minute. Temperature was 99.9 degree Fahrenheit. Respiratory rate was 24 per minute. Patient was initially stabilized and planned for an emergency dialysis in view of severe metabolic acidosis. Dialysis catheter was introduced and placed under ultrasound guidance in the right internal jugular vein under platelet coverage without any bleeding complication. Next slide. This image shows a USC guided central venous access. USC guided central venous access increases the first attempt success rate and decreases complication rate. The picture shows ultrasound guided catheter placement in a sterile fashion. The universal precaution is mandatory and as appropriate should be applied. High frequency linear probe is best suited for central venous catheter placement. The steps for USC guided placements are as follows. Next slide. The first step is to identify and localize the vein and trace the relationship between the arteries. Vein is identified in the short axis transverse view or long axis longitudinal view. As seen in the left hand side of this image, with probe marker pointing laterally, vein is located lateral and the artery is in the medial. The differentiation between the artery and the vein can be made out by compressibility of the vein. So here we can see the vein is more collapsible comparing the artery, and the exact differentiation between the artery and vein can be made out by color Doppler. Next step is to evaluate the brightness of vein, and the real-time ultrasound guide is used for puncturing the vein. So previously, in this image, we can see the needle position in the center of the vein. In this image, over the left-hand side, we can visualize the needle as a dot in short axis view, and in the long axis, the entire length of the needle is visualized. Next page. After confirming the needle position, we have to confirm the wire position and place a catheter on the wire. And after confirming the wire catheter position can be seen as the above image. We can appreciate the catheter inside the vein. Next slide. As cited by several articles, several studies suggest that ultrasound guidance improves success rate and decreases complications when compared to static approach or traditional landmark technique. Next slide.
So it's time for the next poll question, which is, which ultrasound probe is best suited for CVC line placement? Answer A, answer B, answer C, and answer D. High frequency curvilinear, low frequency linear, high frequency linear, and answer D will be low frequency curvilinear. Okay, the answer would be C, high frequency linear probe. We'll move on to the scenario 5.
So postpartum hemorrhage. We had another interesting case, 33-year female, referred from a public health center after a vaginal delivery. She had a hypotension within 3 hours of delivery. BP was 60/40, pulse rate was 144 per minute, respiratory rate was 24 per minute, and saturation was 98% in the room. Our GCS was 14/15. Our abdomen examination revealed a rigid abdomen with uterus below umbilicus. There was no PV bleeding. Patient was initially stabilized as per guidelines, and after stabilization, we moved on for a bedside ultrasonography, which revealed free fluid in the hepatorenal space and pouch of the breast. The left-hand side image is from the patient, which we can see a free fluid in the Morrison's pouch, that is hepatorenal space. On the right-hand side of the screen, we can see the collection of free fluid in between urinary bladder and the pouch of the and the uterus in the pouch of the breast. As we discussed earlier in the EFAS algorithm, the patient with unstable patient with EFAS positive, the patient should be evaluated in theater. We immediately shifted the patient for further management there, where in the intraoperatively we found the uterus was ruptured with hemiperitoneum. Thus, the bedside focus gave us the clue for the cause of instability, and we successfully resisted the patient. Acute shortness of breath. A 32-year male presented to emergency with sudden onset of breathlessness lasting for 1 hour. He had a history of chest pain for 2 hours. The patient also gave a history of travel more than 12 hours in bus a week ago. He's a known smoker for more than 7 years. he smokes 6 to 7 packs per day. The patient was initially assessed and stabilized according to the protocol. On arrival, his GCS was 15/15. His pulse rate was 138 per minute, and BP was 80/60, and saturation was 98%. His respiratory rate was 36 per minute, and temperature was 98.4 degrees. We had an ECG for this patient, which showed an ST depression in lead 3, lead 1 with pathological Q wave, and T inversion in lead 3 with RVP pattern. Next slide. So this is a bedside focus echocardiogram. With in this the left hand side of the screen reveals a dilated right atrium and ventricle in an apical 4-chamber view. We can also appreciate the right atria and ventricles are grossly dilated when compared to the left atria and left ventricle. In normal patients, the left atrium and the left ventricle appears enlarged compared to the right atrium and the ventricle. In the right hand side, we have the short axis view, which shows the flattening of interventricular septum and resulting in a D sign. Next slide. This is a focus echo video. In the left hand side, the image shows D sign in the short axis, and we can appreciate the tricuspid regurgitation in the apical port side view of in the right side. Next. In this patient, we had a high suspicion of acute pulmonary embolism. We confirmed the finding with standard clinical methods, and we initiated on thrombolysis with injection articulase in our emergency itself over 2 hours. Later, the patient was diagnosed to have an elevated homocysteine level, which is a high risk factor for thromboembolism. Next.
Okay. 7th poll question. The scenario would be patient with pain in the right lower limb presented to the emergency department. An ultrasound was done. Identify the finding. So this is a focus of the calf muscles who was presented to the emergency department, where you're seeing an artery and a vein. A compressibility test has been done. What is the probable finding in this patient? The time starts now.
You type in the answer now. Okay, time's up.
The answer would be right femoral vein thrombosis.
Yeah, quite a number of the audience write down the clot in the common femoral vein, and the vein is non-compressible.
Back-to-back poll question. The question would be, McConnell sign is defined as a region of pattern of dysfunction of which heart chamber? Left atrium, left ventricle, and right ventricle. The time starts now.
Okay, time's up.
That's the right answer. The answer would be D, right ventricle. So we'll move on to the next, which is application of focus in cardiac arrest.
So we can see that when there is an ongoing CPR, if the patient has arrested, we let the CPR to go on. We just detect the rhythm, whether it's a non-shockable rhythm. Usually this can be done, the focus ultrasound, in a pulseless electrical activity or asystole. We can see that the CPR continues as per the algorithm. In the meanwhile, the person who is in charge of performing the focus CA, he prepares for the equipment. We should make sure that the focus ultrasound should never take more than 10 seconds. And then we proceed, and during the compressions, we don't record we don't evaluate the rhythm. We just take the record, and then we evaluate only when there is a time for compressions. And then we can see in the next slide. See here, you can see that the first in the initial CPR phase, we just see that the patient person preparing, the placement of probe on chest. Then there is a pause for the record clip. Usually we don't evaluate because there can be delay for the restart of the compressions. We should make sure that we minimize the interruptions. Then we need to review to see if there is cardiac activity. The presence of cardiac activity will indicate that the chances of return of spontaneous circulation, ROSC, is high. And then we also look for some abnormal findings such as phi heads and phi Ts, which are the reversible causes of pulseless electrical activity. And then we intervene after discussing the clinician who has done the focused cardiac ultrasound discusses with the CPR team and then decides for the intervention. So other applications of focus in emergency department. So we can see this is a lung ultrasound. The first A image shows that this is a normal lung ultrasound with A lines. A line represents horizontal hyperechoic lines. These are the reflections of a pleural line. This is a normal image. The B line indicates the vertical B lines extending from the pleural line to the end of the screen. Here the normal one, less than 3 per field will be normal, but when there are more or when they are confluent, they indicate pulmonary edema. The C image indicates air bronchogram, which is indicative of pneumonia or consolidation. The D image, you can see there is collection of fluid with compressibility of the lung has been collapsed. That is, you can see the arrow in D image, which is a collapsed lung because of collection of excessive fluid, that is pleural effusion. And in the E image, you can see there is discontinuity, which indicates there is a traumatic fracture. And also it has a role apart from other applications. It can be used in pain relief. You can see the picture depicting ankle block using the high frequency linear probe with the deep peroneal nerve, superficial peroneal nerve, saphenous nerve, sural nerve, and posterior tibial nerve. So this is a consolidated complete image showing all the 5 positions for the ankle block. And this is an image wherein this is airway focus. This is for the conformation of the endotracheal tube. You can see the double lumen sign. And also it's helpful in to identify the cricothyroid membrane. As you can see, the cricothyroid membrane, this can be helpful in cases of surgical cricothyroidotomy to just know the anatomy prior to placing the lead.
So we are into the last few slides before we complete our presentation. The recent advances in focus, which includes ultrasound had become more portable, user-friendly, and accessible. Pocket probes offer cloud-based platform for remote viewing too. The advantages of the focus include improving diagnostic accuracy, decreasing ED length of stay, improving patient satisfaction, improving procedures, success rate in the invasive procedures, and decreasing procedure-related complications. So this is one of the many studies we have to make an impact of point of ultrasound in decision making. And this is the last slide of our presentation. Some of the few take-home points. Though ultrasonography has become an integral part of emergency medicine since 2 decades, and the focus is ideal for evaluating 262 shift patients, the training of emergency physicians and residents in the goal-directed therapies positively influences the patient outcome. But we understand the importance of ultrasound in acute care, but the constraint is its accessibility. In a limited resource ER setting or when ultrasound machine is not, and if operator not trained for the same, there should always be a basic plan to cope up with the situation. So POCUS is a powerful adjunct, but never a replacement for a proper history collection and a thorough physical examination. I once again thank you for the opportunity to a team and sincerely thank all the delegates for patient listening. Good day to once.
Thank you very much for Professor Raja Duray and also Dr. Manus and also Dr. Khanna for their presentations and also the sharing of our various cases on the POCUS in the applications for various conditions in emergency medicines. With this, a really a powerful tool for us. Probably in future we will. Many people have said that basically ultrasound is another stethoscope for emergency physicians in the department. So let me thanks again for the Professor Raja Duray and his team. And because of the interest of time, I would like to pass the mic to the second speakers. Actually, it's our guest speakers, Dr. Ted Hassan, and he is the consultant physicians in the Leeds Teaching Hospitals in UK, and also he is the past president of the Royal College of Emergency Physicians, Emergency Medicine. But this time, well, his focus is not on those related to his work in UK, but because he has passions to facilitate the development of emergency medicines especially in South Asia. So this time he's going to represent as the chair of the South Asian Collaborative for Emergency Care. The talk he was talking about is about the driving education, training, and advocacy for the development of the South Asian Collaborative for Emergency Care as part of the Asian Society for Emergency Medicines. Let's welcome Dr. Ted Hassan.
Axel, thank you so much. I hope you can hear me okay.
Yes.
Perfect. Okay. I'm just going to share my screen if that is okay. And so that we can get on to the
Yes,
slides.
we can see clearly.
Okay. So just, can you see the slide?
Yes. Perfect.
Okay. Perfect. Let's see if I can minimize that further. Okay. Perfect. So you can see the first slide, yeah, and you can hear me okay. So thank you first of all to Axel and to the Asian Society for kindly inviting me to this excellent track. I really enjoyed, I only joined half of the last lecture, but it was really excellent. So thank you for that. So as Axel said, my name is Taj Hassan. I'm a consultant in emergency medicine in Leeds and hold the honor of being chair of a new group called the South Asian Collaborative for Emergency Care, SACEM. And what I want to do is to talk to you for probably only about 15 minutes or so, and then take some questions about SACEM and what we're proposing in a program called the Collaborative Halo Program for South Asia, but really it's for Southeast Asia, and the fact that it sits and is strongly endorsed by the executive of the Asian Society is great news. And so I hope you enjoy it. I hope it stimulates discussion, and very happy to take questions at the end of the talk. So let's see, what are we going to talk about? We're going to talk about why it's important, what we're proposing, and how we intend to move forward from the present day into over the next few months and years. As we know, the scale of the challenge is huge. WHO have described over many years the challenges in Southeast Asia, and this is just one small statistic around trauma deaths and the impacts on avoidable harm that we can institute if we have good emergency care systems. And you will know that there in 2019, they produced this graphic on what all nations should aspire to in terms of an emergency care system framework, both in terms of pre-hospital care transportation to receiving centres, and then what should be provided at receiving hospitals, both in emergency departments or emergency care facilities, and then subsequently in the hospital, so that we can reduce avoidable harm for medical emergencies and trauma, and get patients back into the community, either self-caring or caring with their families. So these are huge challenges. I've been lucky enough, I'm originally from Pakistan and been working predominantly with colleagues in Pakistan, but while I was at the Royal College, I was lucky enough, obviously, to visit India. I previously visited Bangladesh, and we've been really keen to work in the SAARC countries predominantly in the first instance. And so, you know, the South Asian area is home to 1.8 billion people, which is 1 in 5 people on the planet. And yet there are probably less than 3,500 trained emergency physicians. So it's a huge challenge. And what we want to do through working collaboratively and together as the SACEM group is to be able to share our expertise and be able to fast track emergency care development. The SACEM group came about over the last 12 to 18 months after lots of discussion. And I've just been really privileged to work with the executive committees of India, with SEMI, of Pakistan, Nepal, Bangladesh, and Sri Lanka and Bhutan. And we've come together to create SACEM, as I say, to be able to share our experiences, to share knowledge, and to be able to drive forward emergency care development. The what of what we want to achieve, we want to improve education and training and share our resources. We want to advocate. So some countries, especially in Bangladesh and Sri Lanka and Pakistan, I think India is significantly ahead in emergency medicine development, but these other countries really need advocacy to help their governments decide that emergency medicine is really important. And our ultimate aim, obviously, is to improve care delivery and save avoidable death. How are we going to do it? So what we've done is, as I say, build a collaborative network in the first instance. We want to build upon that by creating a registry of subject matter experts in key specialties, and that the opportunity to create this as a South Asian community in the first instance, but really in discussions with Axel, you know, we're really keen to build this out and get the support of the Asian Society and have fantastic collaboration with other colleagues in Southeast Asia as well. So it's fantastic to have endorsement from the Asian Society as well as IFEM to be able to share expertise and create some momentum. And the vehicle for change, for making that happen, apart from building the network, is what we've called the collaborative halos in emergency care. And I'll come back to what that stands for. The other thing that I put this in as a slide, I'm lucky here in Leeds to be the director of KailTech, which is titled the Centre for Augmented Intelligence Learning and Technological Integration in Emergency Care. And our aim here is really to use technology to drive improvements in emergency healthcare. And one of the key components to this is the Enlighten Me platform that we built, which is just beginning to take off. We've hosted a couple of international meetings with South Asia, and we feel we can build that out, not only to provide free access to e-learning, but also to be able to provide other future courses, either as webinars in collaboration with colleagues or as well as face-to-face learning in the future. So KailTech you can look up on the web, www.kailtech.org. So what is a HALO? What we want to do is to create collaborative hubs of academic learning organizations in emergency care. This is about collaborating with colleagues in South Asia on existing centers of excellence with colleagues internationally across 4 domains. So this is clinical care, leadership, we believe is really important, and we want to develop a leadership academy. Simulation is really important, so a simulation academy, and also then to drive quality research and innovation. I noticed the excellent talk on ultrasound earlier, and obviously that ultrasound is a fantastic medium, and that would fit in really well with clinical care, as we discussed. So those are the 4 key domains that we want to collaborate and drive forward. There is no doubt that there is existing expertise already in some of these centers, and we want to help and augment and drive and fast track that process through the developments of these HALOs in South Asia over the next few years. The vice chair of the SACEM group is Imran Subhan. Many of you know, past president of SEMI, and the executive of SEMI have been fantastic, as have the executive committees of the other nations as well. So how are we going to do it? It's a combination, as I said, of technology, e-learning, running collaborative webinars like the ones that you've kindly organized today. And then in the future, what we want to do is develop face-to-face teaching and train the trainers programs in those nations so that we can create a halo effect and drive forward so that colleagues can really embed that within their own systems. So step 1 to that process, step 1 is around structure. How do we build these collaborative halos? And it really is about building a network of an international faculty and local partners, developing quality assured content that we can then link to certified courses with local academic partners. And we will need faculty and managerial resources, and we're trying to develop some funding around managerial resources here in the UK from South Asian diaspora. And we think that over the next 6 to 9 months, that funding will come good, and that we will be able to support HALO developments in those nations with some funding, as well as with the e-learning platform. Step 2 is really just then beginning to get much more detail around the Enlighten Me platform, which is the e-learning platform, and in the future, how we might build, a virtual ED environment using augmented and virtual reality, which would fast track things even further. Webinars, as I talked about, there are really excellent webinars that already run, but we want to be able to link that together to produce a blended learning solution and support system change in some of these centers. And then finally, as I talked about, face-to-face teaching so that we can create and enhance faculty development in leadership development, simulation, and also psychomotor skills, whether it's ultrasound or practical skills in the future. Step 3 is then a much more challenging set of outputs supported by the international and local faculties, supported by the blue blocks that we just talked about earlier. And that will then allow us to deliver these certified courses and quality assured. So Imran Subhan chairs the WHO committee on IFEM and is really keen to drive WHO courses, many of which have already run. We want to be able to support local curriculum development. We want to support RChem courses that may want to evolve. Some of you are in RChem centers already. We want to support international medical graduates who might wish to travel to the UK, but we think that really this program, the HALO program, will invest back in South Asia so that it creates much more of a balance of giving back rather than potentially creating a brain drain. And then these other things that I've talked about, the Leadership Academy, the Simulation and Quality Improvement Academy. So how are we going to do it? What have we done? We've built this website through some charitable funding. It's called the Enlighten Me website. You can access it at www.caltech.org. And what we want to do is really, over the next 6 months, first of all, build out to be able to get the right multidisciplinary experts so that when we launch it officially, it's in soft launch, but when we launch it officially, this program next year, then it'll have fantastic content. We are building an international group of experts through SACEM. It's been endorsed by, as I said, by IFEM and also by the Asian Society. We want to outline modular designs for these. We've created links to South Asian diaspora here in the UK, who would then support us through funding opportunities. And we're beginning to build relations with major centers in South Asia to act as the pilots in the first instance. How can you help us if you wish to contribute and work together with us? We'd be delighted. We want you to join us on this learning journey with the HALO program. Ultimately, you will get free access to the e-learning materials on the Enlighten Me platform when it formally launches, and obviously future opportunities to then become a HALO center, even if you are in South Asia predominantly, but it may be that we can broaden it out further. If you want to ask for further information, please contact me on that email and I can give you further information as required. That's about it. I hope I've not been too fast on that. The key next steps are building these collaborative networks, strengthening our partnerships, and building these really achievable outputs so that people feel that there is a real use to contributing and that they can avail and help us fast track emergency care developments for that part of the planet. Thank you very much. It's been a pleasure talking to you, and I'm happy to take any questions that you may have.
Thank you very much for your presentations and your introductions on the SACEM. And actually, we can see your passions on the development of the emergency medicines in southern part of Asia. And definitely, I think quite a number of us will be willing to help, especially the Asian Society for Emergency Medicines. Actually, we would like to give a hand to facilitate the development of emergency medicine there, so that we can make the Asians emergency medicines stronger and stronger. Well, any audience would like to ask questions, you can either to text in the chat box, or you just show your raised hands signal here, and then we can allow you to turn on your mic to speak. So while we are waiting for the questions, I would like to ask the first questions to have. Actually, what will you expect the difficulties to implement your HALO programs?
Yeah, thank you. That's a really good first question, Axel. I think we've tried various initiatives in the past, and one of the key things that I've learned a lot is that there is obviously great enthusiasm at the beginning, and I think keeping it very tight and deliverable, and being able to maintain communication, and also getting resource so that we have managerial resource to support the developments, and we're driving that forward here in the UK through a number of initiatives. So there are effectively sort of two key networks. One is in Southeast Asia around faculty development, and also internationally. Well, three networks. One is South Asia, predominantly in the first instance through the executives of these nations. Secondly is the international international faculty, and I think it's fantastic to get such strong support from Southeast Asia. And then thirdly is the network that we're building here in the UK of charities who will then help us fund the further development. So we're trying to really do it in a very staged manner, which is why the official proposed launch is still maybe 7 or 8 months away, because there's a huge amount of work to be done before then. But I think those are the major challenges. I think if we take it step by step, I think we could really have a fantastic collaboration together.
Yes, I agree that we are looking forward for more partnerships in futures. So let me see. I guess. So any questions from our audience? In fact, we have also some BRICS persons from our EM World in Asia to join this meeting. We have Dr. Carol Wu, our president of the Hong Kong College of Emergency Medicine, and also we have Dr. Faith. She is our Asian representative in IFEM, and also Dr. Pauline. Pauline is our president-elect in the ASEM, in the Asian Society for Emergency Medicine.
No, that's great news. I mean, just to add a little bit around collaboration. So, I've discussed this program when I was on the board of IFEM as well, and IFEM is very strongly supportive. The new president is Fionn Davis, previously Sally McCarthy, both strongly supportive of this. So, it's great to have two international organizations, the Asian Society and IFEM, strongly supporting this. And as I say, funding is always an issue, and I think what we're trying to do is to create that network here in the UK, so that ultimately, we can broaden it out as well. But I think if we can create that funding platform, then I think we'll be able to drive it forward really well.
Yes. Well, I think in future, most of us will like to give a hand, and also the Asian Society for Emergency Medicine can work as a platform to help you to collect and to gather those who like to give a hand to the SACEM as a faculty to facilitate trainings. Probably the ASEM will be happy to do such tasks in future.
Brilliant. No, that's fantastic. Thank you.
So, is there any other questions? Dr. Faye can mention about there will be a research collaboration similar to the previous experience of PAROS and PATOS. This is the Pan-Asians research outcomes study, and also the trauma outcome study, so that they can work with SACEM to do on those resuscitation and trauma outcome. And yes, they all agree to give a hand to support your project in future.
Perfect. Thank you so much. Thank you for your time today. It's really kind.
Okay, thank you very much, Tack. It's really a very passionate and also a meaningful project for all of us in future. So we'll keep in touch so that we will let our members and also our colleagues know what we can help in future. Thank you very much, Tack.
That's perfect. I'm sorry I had to rush off to another meeting, but thank you for fitting me in. I look forward to working with you in the future. Bye, everyone. Bye-bye.
Bye-bye. Keep in touch. So time fast, and then we are going to proceed to the last sections. It's the OSCE. This time the presentation will be prepared by our Philippines colleagues, Dr. Pauline Covancas. She will lead us for her presentations on some OSCE questions. I'd like to pass the time to Pauline.
Thank you, Dr. Axel, and thank you very much for having me here. Good evening, everyone. I'll just share my screen. Can you see my screen? And
Yes.
audio okay?
Yes.
All right, perfect. So let's start. So as a disclaimer, I'd like to thank everyone who prepared these cases, and that I'm currently affiliated with 3 hospitals. So these cases are actual cases and are actually prepared by our residents. So even the questions, they've had a hand on the cases. So let me can you see me still?
Yes.
Because I can't now see you. Let me just that's fine, you just tell me if it's okay this way, but I can't see you, so I can't see any reactions, and I can't also see the chat box. So let me just proceed. So we have 4 cases tonight to be discussed. So welcome everyone to our academic meeting. So our first case is actually a 33-year-old male patient who had pain and progressive swelling of the right leg. So hold on to all of your potential differentials for this case. And so this is the case, this is the patient. And as a disclaimer also, we've had initial consents for the images that we are currently presenting here. So this patient presented at our emergency department 3 hours post-injury, had stable vital signs, but just had sudden onset pain and swelling at the right leg. And if you notice here, the 2 legs are actually not of the same shape and of the same size. There's swelling on the right side, and the patient had no comorbidities. So he was walking, and then suddenly just had pain on the right side. And so presented at the emergency department, and just after 2 hours, the swelling already reached above the knee. And that after that, he immediately sought consult at our hospital. So this is the actual picture of the swelling. And if you notice here, you're seeing punctured wounds on the right middle side of the foot. And because of that swelling, he inflicted a laceration, so self-inflicted laceration in an effort to alleviate that swelling. So for this particular case, with these 2 bite marks or punctured wounds, we may be thinking that this is our first question. So maybe just straightforward. So if you're suspecting that this may be a snake bite, what may be your acceptable first aid measure? So probably, Dr. Axel, let's pull up our Zoom poll.
Yes,
So
everybody
we'll
can
give you a
see.
moment.
You can choose your answers, but just for the local audience, well, we try to put the scenario in the setting in Philippines, not like Hong Kong.
Yes. Yes. So I particularly also chose some not so sophisticated cases to also accommodate our low resource setting.
Okay, time's up,
All right, time's up.
and you can see
Okay,
the
perfect. Yes. So it's quite depending on your your access, and also depending on your line of thought. If you're really thinking that this patient may be bleeding, so probably that's how you chose your answers. But actually, we should avoid the use of tourniquets because they may obstruct now arterial blood flow and may eventually cause ischemia. So instead, we use pressure bandage immobilization. So for this particular case, actually, the mainstays are actually splint and washing the wound with soap and water, but also maybe putting on pressure bandage to alleviate the swelling, and of course wound management. So here is the case now, still the same pictures, but now you can see that there's swelling. There's marked swelling, and they've put several markers to note where the swelling had been in a timeline. So that's very significant with snake bites. So for this particular case, again, same case scenario. Of course, we will be expecting complications, but for our initial potential complication that we need to anticipate in the presenting injury, these are the potential complications that we should think of. So again, let's pull up our Zoom poll. So you may think that these may all be possible, but at the onset, what may be our initial complication that we need to anticipate?
Time's up.
All right. So maybe exciting. So of course, we are anticipating all of these things, but the initial thing that we should consider with the increasing swelling and that these are really such tight fascial compartments and there's increased tissue pressure above the venous pressure, which will eventually result in ischemia. So we have to think of compartment syndrome in this case. Now seeing that there's this swelling and you've seen the picture on the some sort of a purpura or some sort of a coagulation, right? So we have to think about what may now be the potential biting species. So based on the syndromic approach to snake bites, which snake is the most responsible for the bite? So there are just two choices. So let's pull up the poll.
Okay, time's up.
Right, time's up. So again, let's see. All right, so most think that it's a viper bite. And moving on to the next question, let's hold on first to the next question. In this case, will we administer an antivenom or not?
Time's up.
All right, Dakasa, thank you. Let's see. All right, everyone thinks that they will administer antivenom, but then of course that depends on the availability and the indication for antivenom, all right? So let us see here a table which shows us the syndromic approach to snake bite. So we have 1, 2, 3, 4, 5 syndromes, but for this particular case, there was only local swelling and there was, you know, the coagulation disturbance in that particular site. So it's more likely that it is a viper species. So in the Philippines, we have our own cobra and we have our pit viper. So in Asia, it's quite common to have snakes, but we have to differentiate, of course, what kind of snake, because we may inadvertently give antivenom, which in a case that's not indicated. So true enough, they have decapitated the head of the snake who bit the patient. So it's the same as that of the viper. So the diagnosis is actually multiple punctured wounds, secondary to the venomous snake, which is a viper on the right foot with impending compartment syndrome. And the mainstay of the treatment is supportive and antivenom only if indicated and available. But since antivenom for viper snakes is not available in the Philippines, so we just gave the patient tetanus prophylaxis, antibiotics, and pain reliever. But we had our section under the internal medicine service for this particular hospital. So we referred the patient to a toxicologist and a toxinologist, and general surgery and hyperbaric medicines for the difficult wound management. So for the outcome, there was no immediate surgical intervention warranted for the patient. So we just continued monitoring for the signs of compartment syndrome. So the patient also had several sessions of hyperbaric therapy and was eventually discharged, which was uneventful of the hospital stay. So let's immediately move on to our next case. So our next case is actually quite interesting. Our next case is a 57-year-old male patient presenting with seizure, but with history of hepatic mass. So quite interesting because the patient presented at the ED with post-ictus. The complaint was that the patient had altered sensorium and upward rolling of eyeballs, but eventually regained consciousness. And the patient had stable vital signs upon presentation. So this was 3 hours prior just your upward rolling of eyeballs, and then regaining consciousness after 20 minutes. But 4 months ago, he was treated for hepatic mass or abscess via ultrasound and was given 3 months long of metronidazole 4 times a day and sultamicillin 750 milligrams 2 times a day. And they note that the hepatic mass decreased. So this is really clinical, but we have to have also a high index of suspicion, right? So the patient had diabetes, hypertensive, but was really compliant to medications. And the rest of the P was really unremarkable. So there's a lot of differentials for this particular cause of the seizure, but I just would like also to pick your brain as to what for you may be the cause for the seizure. So once again, Dr. Axel. There's a lot. I know there's a lot, but let's just see how this goes. So maybe you were thinking that the mass in the liver may not be abscess after all, or you may be thinking that this patient had some sort of an organic, really structural cause to the brain. So this was really undifferentiated, right? So let's see.
Okay, time's up. Let's
Right.
see the pattern of the answer.
Okay, so I will not answer first, but let's see. So they're really thinking that it's a septic thing and that there's hematogenous spread from the hepatic abscess. So let's see. So the CT scan actually for this patient is unremarkable. So I just not show that, but it was unremarkable. And the rest of the laboratory exam was not contributory. The anemia was because of the chronic disease. And they were thinking that this patient was having hyperglycemic crisis as well, which may also cause, again, metabolic causes of potential seizure, but it's not that high. The sodium is not that low as well. So it was like a diagnostic dilemma for everyone. So actually, with high index of suspicion from the clinicians, we also referred this case to a toxicologic specialist. And because of the prolonged use of the metronidazole for the hepatic abscess, there was really this potential neurotoxic cause or neurotoxic effect of metronidazole. So it's really not dose dependent, even if the therapeutic range was observed, but because of the prolonged use, it is actually just fully reversible if you just discontinue the drug. So that's our second case, quite an interesting case. So you just have to have high index of suspicion that it may be possible that there may be other causes, but in this particular case, it's still possible to have neurotoxic causes of the use of prolonged metronidazole. So for third case, quite also straightforward, but maybe also again, clinical dilemma. So a 44-year-old male patient with lacerated wound to the neck. So this is the case. The patient presented at the ED 2 hours post-injury, fell on a held knife. So it was occupational, he fell on a held knife. But the patient presented at your ED not quite in distress with 95% autosaturation, stable vital signs, not really bleeding. But when he speaks, there you note that there's saliva coming out from the wound. So there's some sort of really a breach in the airway and at the same time a breach in the esophagus or the gastrointestinal tract. So this was a case of a penetrating neck injury to zone 2 and was an occupational injury. But the dilemma is this: how will you now manage the airway for this particular case? Will you establish a surgical airway or will you perform endotracheal intubation? Dr. Axel?
Okay, time's up.
All right. So we know that we have really indications for a crash airway or elective airway. But for this particular case, it's actually really a dilemma for the emergency medicine team and the trauma team, because either way, there may be really indications as to your choice. So most of us emergency physicians would intubate the patient. So in all actuality, they did intubate the patient, and they chose to intubate the patient rather than convert or make another wound to perform a surgical airway. Because the plan for this patient is a direct to operating theater for wound exploration and repair all of those injuries. So the diagnosis is all of these. There was even this laceration on the thyroid, the inferior lobe of the thyroid. There was breach in the esophagus and the trachea. And that, so the plan was that of a neck wound exploration with lobectomy, and then eventually they had isthmusectomy, primary repair of the esophagus and the tracheal injury in the drain. So what they did actually is bypass the wound. So you note that there's this wound traversing through the trachea and that of the esophagus. So what they did is actually bypass the wound bypass inferior to the trachea and the esophagus injury, so that they'll be able to explore the wound and repair the wounds. The trauma team and the trauma surgeon decided, and the emergency medicine team have both decided that it will be an endotracheal intubation instead of a surgical airway. So they did also esophagogram to note really that there was no breach, so that a fistula will not be formed after repair. So this is now the esophagogram. So there was no breach. And actually the patient was discharged with no comorbidity. So had it been a surgical airway, there may be more comorbidities for this patient. And that hole at the bottom, at the inferior side, is actually for the drain. So the patient was discharged well and coping very well. The last case is actually a very relevant case since it's rainy season today, these few months. And most Asian countries are actually very prone to flooding. So I've chosen this last case, which is who is a 28-year-old male with fever and icterus. So it's quite straightforward. It's just a matter of question and for our review. The patient is a 28-year-old male presenting with calf pain, icterus, and fever, and borderline normal BP, but febrile. Of course, there's so many infectious diseases out there, emerging and re-emerging, and we have to think about all of our differentials. So the patient had history of wading in floodwaters 3 days prior to the consult, and that the patient developed now body weakness, yellowing of the eyes, and pain on both legs, and decreasing urine output. And the patient tolerated symptoms until the day of the consult, where on presentation, he also had difficulty of breathing. So again, these are our poll. So knowing that, depending also on on which center you are, and you have all the access to all diagnostics, what may you do for this particular case? Let's pull up the poll, Papa Axel.
It's coming.
All right.
Yes.
This is our last case.
Okay, time's up.
All right. So regardless of how sophisticated your center may be, this case I just would like to remind everyone that we have to go back to history, and that it may not really take sophisticated laboratories and decision points if we indeed choose to send our patients for more laboratory or to immediately treat the patient. So most of us actually would want to start antibiotic early for this patient, probably knowing that this case is actually severe leptospirosis. It's quite straightforward, but probably what I just wanted to drive in this particular academic meeting is that we need not do so many laboratories if we already know the endemicity of leptospirosis in Asia and many other things, right? So for this case, we were thinking of acute kidney injury, and that's very important that we have our own epidemiologic criteria, and it's already given that we may already recognize leptospirosis clinically. So for healthcare practitioners, we should be alerted for any cases, even if like right now, all fevers are considered COVID unless proven otherwise. We still also have to think about our trends. It's flood season, and that we just have to really remember that we may have our triad. So cases may still present classically, or they may still present with different they may present differently again in some other ways, and you may get confused sometimes with a classic presentation versus that of an additional presentation or severity of the disease. So for the rest of my slides are actually just review and the differences of presentation across countries, but the most common presentation is of course the triad, and that of if this is a severe leptospirosis, we also have to think of other treatment modalities and not wait for the laboratories or the diagnostics for this particular case. So the risk of mortality is also very important. Our patient is relatively very young, but we have to look at respiratory insufficiency. Remember, our patient already had difficulty of breathing. So altered mental status is one risk for mortality. Oliguria is one again. Hyperkalemic acute renal failure is one, and of course, cardiac involvement. So for this case, despite that clinical criteria or epidemiologic criteria, the team who managed this case still decided to, of course, proceed with our diagnostics. And indeed, the leptospira antigen were positive, but the patient is not really hyperkalemic. The potassium was just 3.3, and again, hyponatremia, but it's not that high, it's not that low. And 26, so the patient was septic at WBC. So these are just limited diagnostics. Of course, other than that, we have to also look at the other parameters, and the X-ray is actually unremarkable. So just to review a bit, the indications, perhaps for renal replacement therapy, should it be indicated for this case, but it's not. And then also you have to review as well how to manage your fluids, if your patient is oliguric or not. And if you don't have your epidemiological criteria in your country, you may also consider really our confirmatory diagnosis only if it's warranted and for our public health reasons that there are no locally available epidemiological criteria. So probably I'll end there, but this is actually the take-home message that it should be started immediately, antibiotics, as soon as the diagnosis is suspected and regardless of the phase of the disease or duration of symptoms. So the sources are, of course, Philippines, but since we have endemicity of leptospirosis, and it's very common, so I'll just leave it at that, and then probably we'll take some questions, or I'll send you the link for our sources. And if you notice, to end my presentation, there are subliminal messages at the bottom of my slides. So I'm inviting everyone to the ASEM 2023. This will be on April 28 to 30 in the Clark Freeport in Angeles City, Philippines. So thank you very much once again for the opportunity, Dr. Axel, and we'll meeting everyone soon. Good evening.
Thank you very much for calling. Very, very interesting case. In Hong Kong, we occasionally will encounter the few cases of the leptospirosis, especially after the heavy rain, flooding. We occasionally see some cases, but probably because of the frequency was not so great compared to Philippines. Sometimes it takes some time for us to make the diagnosis. So any other questions from the audience in Zoom? You can type in. Okay, I can't find any questions. Probably they all satisfied with your presentations. So, I can see one questions. Yeah, there's one questions from the Dr. Here is the emergency physicians, and now he's stated in Australia.
Yes, that's a very interesting question, Dr. Ng. For this particular case, it was the trauma team who have decided on the choice of the airway management. Since they've decided to go to OR immediately, there was this decision to not do the CT angiogram, but proceed with the definitive OR. So it was the trauma team's decision to proceed with the surgical plan. So they proceeded with the repair. So I hope I could have invited the trauma surgeon here, but unfortunately not. What's the driving point for this case is just actually how it was managed at the ED level.
Thank you. Well, any other questions from the audience? Okay, if no, I really would like to take this opportunity to thank Pauline and also the Professor Roger for their teams, and also for your contributions for the material to be presented today. And well, I'm happy to have this kind of the meetings, and also we plan to the ASAM. We plan to have the next academic meetings in November. Probably will be on the 25th of November. So for those who from the other than Hong Kong, that if they want to request for the certificate, the electronic certificate attendance, please send a request to our official email. There's Asian Society EM at gmail.com, and I just yes, I just add this in the chat box. Although for those Hong Kong delegates, we'll soon post up the QR code. You can use the QR code to claim your training points or the CME. And do remember, mark your diary, 28 to 30 April next year. Next year. There's a typo. Next year. Save the day, so that hope everybody can visit Philippines, the Clark City for Philippines, to attend our next Asian conference on emergency medicine. So Jackie, you can post up the QR code for our guests, please. Thank you. So I would like to conclude the meeting today, and do enjoy the day or enjoy the evening. Thank you very much. See you next time.
Thank you very much. Good evening, everyone.
Bye.
Bye.